Good morning and welcome to today's webcast, 2018 Medicare Regulatory Update for Hospitals. Before we get started, I'm going to play a brief housekeeping video.
Welcome, and thanks for joining us. We're pleased to present another in our ongoing series of continuing professional education webcasts to help companies and individuals conquer challenges as they plan for what's next. Our presentation will start in a few moments. Before we begin, here are a few things to keep in mind. You can customize how you both view our presentation and interact with the presenter. For better viewing, close all other applications and turn up your speaker volume. You can also adjust window size and placement or enter full screen mode using the controls at the top of the window or dragging the bottom right-hand corner to resize. At the bottom of your screen, you'll see a series of icons, each relating to a different aspect of our session. You can download the group attendance sheet and a PDF copy of today's slides from the slide deck and handouts widget to the right of the slide view. You can ask our presenter questions during the webcast by typing a question in the Q&A window below the slide view and clicking submit. We'll do our best to answer all questions during the presentation or follow up via email. If you experience technical difficulty during today's presentation, refresh your browser by hitting the F5 key. Today's session will offer you 1 CPE credit. To receive credit, you must meet the requirements as specified by the National Association of State Boards of Accountancy. You must attend at least 50 minutes of the session and respond to at least 75% of the polling questions, which we'll ask throughout today's presentation. To respond to a poll, click the button next to your answer. We'll track your progress and alert you when you've earned CPE credit. You can then click the certificate icon in the CPE Progress widget to open a PDF file that you can save to your computer. Don't worry if you can't download your PDF certificate today. We'll email a copy to you in 2 weeks. If you're attending this webcast in a group, you must complete our attendance sheet to receive CPE credit. The attendance sheet is available in the slide deck and handouts widget. Please have all group members sign it and send only 1 sheet per group. Also note that CPE credit can be awarded only to participants registered as themselves and isn't available to participants who view the on-demand version. As a reminder, the presentation you're about to see isn't legal, investment, or accounting advice. We encourage you to seek the counsel of a professional service provider to apply this content to your specific circumstances.
I'm happy to introduce today's speakers from Moss Adams, Glenn Bunting, Director, and Paul Holden, Senior Manager. Glenn has over 25 years of experience serving healthcare organizations with an emphasis on Medicare and Medicaid reimbursement and related billing and coding issues. He assists in overseeing the Healthcare Consulting Group's third-party reimbursement practice, including charge capture services, cost reporting, appeal services, and medical education programs. Paul provides reimbursement consulting and business assurance services to healthcare providers in acute and post-acute settings throughout the Western United States. He prepares Medicare and Medicaid cost reports, assists clients during third-party audits, formulates appeals of audit issues in connection with cost reports, and assisting hospitals, sole community hospitals, critical access hospitals, rural health clinics, and federally qualified health centers with billing and reimbursement issues. Glenn, I will now turn the line over to you to get us started.
All right, thank you, Emily. And good morning, everyone. Welcome to the Moss Adams Annual Medicare Regulatory Update for Hospitals. Each year, CMS publishes a proposed rule of changes to the inpatient Medicare payment system. This happens in April. They allow for a public comment period, which generally takes place in April, May, and June. And then in August, the final rule is issued. Our presentation today is intended to highlight the major changes set forth by CMS in the Federal Register dated August 14, 2017. We will also touch base on a couple of other topics outside of this Federal Register. So let's take a look at today's topics. We're going to spend some time today addressing wage index deadlines, the inpatient prospective payment system final updates for 2018, DISH and uncompensated care, provider-based update, and we'll touch on the outpatient prospective payment system proposed update for calendar year 2018, which just came out a couple months ago. Wage index and geographic reclassifications. Geographic reclassification requests which are intended to move a hospital from one core-based statistical area, or CBSA, to another for Medicare inpatient and outpatient payment purposes, were due on September 1st, 2017. If approved, this year's class of GO reclassification requests would be applicable to federal fiscal year 2019, which would begin on October 1st, 2018. The September 1st deadline was September 1st was also the final deadline for canceling a previous wage index reclassification withdrawal or termination. So if you withdrew your approved GO reclassification in May or June, you could have reversed your decision if it was filed by September 1st. Nationwide, we currently have 906 hospitals that reclassify from their own core-based statistical area to another area. A couple of changes that were implemented in recent years to the GO reclass process include submitting requests electronically, and there's a new address that was applicable for this year's reclassifications to the Medicare Geographic Classification Review Board, or MGCRB. I find it's very important to read and follow the MGCRB instructions closely, as we find these instructions do change slightly each year. Also, if you did reclassify and you are approved, your reclassification will span a 3-year period. In the Federal Register, the final national average hourly wages are on your slide. Again, these were published on August 14, 2017 in the Federal Register. This data originates from hospital calendar year 2013 payroll information and has been incorporated into the fiscal year 18 Medicare wage index factors in conjunction with each hospital's occupational mix adjustment. So as you can see, the changes noted are very slight. The question you may want to ask yourself is, how does my hospital compare to the national values set forth in this table? Are my nursing values higher than the national nursing averages, which would create a negative occupational mix adjustment? Or are my nursing values lower than the national nursing averages, which would create the opposite effect, a positive occupational mix adjustment? As a matter of background, the Occupational Mix Survey is conducted by CMS every 3 years. The first deadline this is the year that you do submit your survey, and the first deadline was actually July 3rd of this year. And it's interesting to note that 94% of hospitals complied with that deadline, which in my view was a pretty high percentage. There's a second deadline, which again was September 1st, 2017, and that's to submit your initial submission if you didn't submit on July 3rd, or corrections to your original submission. The MAC will be contacting you if you haven't submitted an occupational mix survey by September 1st. Now, what happens if you don't comply? You will still receive an occupational mix adjustment that is an average of the occupational mix data from other hospitals located in your core-based statistical area. Now, that result could be favorable, it could be unfavorable. However, there's one certainty, and that is that your occupational mix data will be based on other hospitals' data. We always encourage hospitals to comply with your MAC and submit your own occupational mix data, if for no other reason than to control your own payment destiny. On your screen is the CMS Federal Fiscal Year 2019 Wage Index Timetable. We're currently beginning to see the MAC ask for documentation supporting filed or corrected wage index and or occupational mix data. And this process is going to continue through the middle of November 2017. On January 30th, 2018, an updated public use file, or PUF file, will be released incorporating the MAC's adjustments to wage index data. Hospitals will be able to view their data to determine if it is accurately stated. To the extent the MAC has incorporated adjustments that the hospital disagrees with, the hospital will have one last opportunity to submit documentation that will reverse or modify the data in dispute. However, new requests to correct data that should have been submitted by September 1st will not be entertained by the MAC. The January 30th updated PUF file can also be used to develop a preliminary wage index factor for the upcoming federal fiscal year 2019 payment period. But it's important to realize that while the wage index data and occupational mix data is solidified in the January 30th PUF file, it is not final and it is still subject to change. So small changes to this data will continue to occur right up to the point where the final wage index factors are released in tables in next year's final rule. On this slide, we've compiled a set of what we call wage index fast facts. There are currently 407 urban CBSAs and 47 rural CBSAs, one for every state, except for 3 states. And those states are Delaware, New Jersey, and Rhode Island. They do not have any rural areas. Instead, CMS has developed an imputed rural floor for these states. So in the proposed rule, CMS had considered letting the imputed rural floor expire on October 1st, 2017. However, based upon comments from the public, the imputed rural floor for these 3 states has been extended for 1 year. Now, due to budget neutrality considerations, the extension of the imputed rural floor has a small impact on the wage index factors for all hospitals nationwide. We're going to have to see how CMS approaches the imputed rural floor in the future. It is definitely something to keep an eye on. It's also worth noting there are 5 states called frontier states. There are 52 hospitals in these 5 frontier states, and they're listed on the slide. Frontier states receive a wage index factor of at least 1, so they have some protection there. There's also what's called an out-migration add-on adjustment that is applied to some hospitals. Out-migration is intended to consider in the wage index employee commuting patterns for certain areas of the country. The out-migration add-on is a favorable adjustment. However, it's not available for hospitals that have chosen and have received an approved geographic reclassification. I think that gets us to our first polling question. Emily?
All right. Our first question is, do wage index factors developed for IPPS hospitals impact the Medicare payment for non-hospital entities, such as freestanding skilled nursing facility or a home health agency located in the same core-based statistical area? And your options are yes, no, or I'm unsure. And I'll give everyone a few moments to respond. To participate in the polls, please click the button next to the answer you choose and hit submit. And we'll give it just a few more seconds here. And let's take a look at their results. Glenn, back to you.
Yes is the right answer. They do impact those entities. There is what's called an unadjusted wage index factor for every hospital. If your wage index factor is adjusted, it could be because you've done a geographic reclass or for some other reason. But in short, the data that is developed and used for hospital wage index is also used for these other non-hospital entities. We're going to continue on with some more wage index fast facts. One thing to keep in mind in terms of the wage index factors that are developed every year is that they are developed from Medicare cost report data that is 3 to 4 years prior or in the past, depending upon your cost reporting period. Sometimes you might find that there's wage index data that is omitted, or maybe the MAC will point that out. And an example we have here is that the dietary and contract labor sometimes is omitted. And the MAC has been known to impute certain data into the wage index information. It's kind of controversial, but CMS has supported this action, and I guess that's kind of the way it goes. Our polling question, we touched on the fact that the unadjusted wage index values derived from hospital data are also used in the Medicare payment models for inpatient rehab facilities, inpatient psychiatric facilities, skilled nursing facilities, home health agencies, ASCs, ESRD, and also hospice. These non-inpatient Medicare providers are not allowed the opportunity to submit geographic reclassifications, and they don't receive rural floor or frontier status protections. So consequently, a hospital with a SNF located in Billings, Montana, for example, will receive two different wage index factors that are developed from the same data. The hospital will receive a wage index factor of 1 based upon its frontier state designation. However, the SNF, without any protection, receives an unadjusted wage index factor of for this year, 0.8863 per the Federal Register. So without its frontier state protection, the hospital's inpatient and outpatient services would receive the same 0.8863 wage index factor that the SNF receives. We've inserted a slide here as kind of what we call a reminder slide about reporting wage index pension expense in the cost report and how you do it. In short, for allowable pension expense, if you have a qualified defined benefit plan, those plans are now based upon contributions made to the plan using a 3-year rolling average, beginning with the current year that's under review and the 2 previous cost reporting periods. All other pension plans, whether it be 401k, 403b, TSA, unqualified plans, the allowable pension expense is primarily based upon the expense reported in your general ledger. So it's critical to know what kind of pension plan is in place at your facility so you report pension plan expense properly in the wage index information. One of the new reporting requirements for health insurance within the wage index worksheet is health insurance. How is it now supposed to be reported? We must now segregate health insurance expense between purchased health care, self-funded with a third-party administrator, and self-funded without a third-party administrator. So this change is now implemented on worksheet S3 Part 4. Also, another change has to do with home office benefits in the sense that they now have to be segregated from home office salaries on worksheet S3 Part 2. So just a little bit more breakout on your cost report when you file. One thing that we've seen in the last couple of years is what's called an urban to urban reclassification. So what this is sometimes an urban hospital will request a change in its urban designation to rural, and this can be for various reasons. We have kind of an abbreviated list of reasons on our slide. But for wage index purposes, using the geographic reclassification process, a rural hospital can reclassify back to its home urban area in order to receive a higher Medicare payment. And this has been a popular trend the last couple of years, and if you are a hospital in this situation, you should give it some consideration. Now, the deadline for filing the geographic reclass has passed. It was September 1st. However, you should give this some consideration just in terms of reclassifying for the next year, because you can reclassify geographically every single year. And again, once you reclassify, they are good for a 3-year period. Volume decrease adjustment requests. We're going to shift gears for a minute and talk about sole community hospitals. There is one major change in the final rule that impacts sole community hospitals. If a sole community hospital experiences a decrease in total discharges of 5% or greater from 1 year to the next, they are allowed to seek a payment adjustment. This payment adjustment is known as a volume decrease adjustment. A volume decrease adjustment is allowed if the hospital can show the decrease in discharges is due to a circumstance that is beyond the control of the hospital. So examples might include a catastrophic event. I know we've had some hurricanes here in the last couple weeks, or maybe an economic downturn in the community, and that's just to name a couple that come to mind. Currently, very few sole community hospitals receive a volume decrease adjustment due to CMS's approved calculation of fixed cost. So consequently, what's happened is that has led to a number of PRB appeals on this subject. So CMS has now modified their fixed cost calculation, and this change will make it easier for qualifying hospitals to receive relief. However, the change is prospective, not retroactive, so that means that this change is going forward, not backwards to maybe requests that have already been filed. The change will begin on October 1st. CMS has assumed their change to the fixed cost calculation will cost the program an additional $15 million, and there will be approximately 20 more hospitals that will qualify under the new methodology. The average adjustment is estimated to be $750,000. So it's important if you're a sole community hospital to be watching those discharges and monitoring it, because if you do experience the 5% decrease and there is some sort of a reason why the decrease occurred, it could be worthwhile to you to pursue a volume adjustment. Low volume hospitals. Another change. Now, low volume hospitals are not sole community generally, but another large change noticed in the Federal Register impacts the hospitals that receive what's called the low volume add-on payment. This change is a large payment take-back by CMS, and it's rooted in regulation and law. In the current year, there are more than 1,200 hospitals that are potentially eligible to receive a low volume add-on payment. These hospitals are potentially eligible because they have 1,600 or fewer discharges and are located 15 miles or more from the nearest DRG hospital. On October 1st, this qualifying criteria will revert back to its original criteria of less than 200 total discharges and 25 miles or more from the nearest DRG hospital. So it's going to get extremely tough to qualify. And what this means is the low volume add-on payment is going to end for most hospitals. CMS estimates low volume add-on payments will decrease from $317 million in this current year to only $4 million in federal fiscal year 18. If you're one of a handful of hospitals that continues to qualify for the low volume add-on adjustment under the original criteria, documentation to support your low volume add-on adjustment continues to be required by the MAC, and it must be submitted annually. The due date was September 1st. If you missed the due date, go ahead and submit the documentation and show that you meet the criteria to the MAC. There'll be a 30-day delay on your payment, but you will get the add-on. It's also important to note, at this point, Congress would need to take action in order to extend the current, more generous qualifying criteria. The payment change being implemented by CMS is not being done at their discretion. They're just simply following the current law. I think, Emily, that brings us to our next polling question.
Yep, our second polling question. Presuming Congress takes no action, how many hospitals nationwide will be eligible to receive a low-volume payment adjustment on or after October 1st, 2017? Your options are less than 25, between 25 and 50, between 51 and 100, or more than 100. And as a reminder, if you would like to receive CPE credit for today's webcast, you will need to respond to at least 3 of the 4 polling questions. I'll give everyone a few more seconds to make a selection. And let's take a look at the results. Glenn, back to you.
Yes, the result is in line with the majority here. The majority picked less than 25. The actual number is really unknown, but before the more generous criteria was implemented, I recall back in time there were probably somewhere, I want to say around 8 hospitals that qualified under the original criteria. So as I said, this is really going to be going away for most hospitals. So at this point, we're going to talk about DRG payment rates, and I'm going to turn the discussion over to Paul Holden.
Very good. Thanks, Glenn. Good morning, everyone. We appreciate you spending some time with us this morning to talk about these new rates that will go into effect on October 1st. So starting with the base payment rate for DRGs, we have two sections here on this slide. The payment rates for those folks whose wage index is greater than 1.0 and those that is less than 1.0. You don't see CBSAs with wage indices less than 1 very often, but they do exist. But as you can see from the table, the base payment rate for either scenario is the same. It's the distribution of the labor-related versus non that changes between the two scenarios. As we've seen in the last couple of years, we have a comparison to last year's final rule to this year's. We have, from the correction notice, we're averaging anywhere between, say, $55 and $75 on a base payment rate method increase each year after all of the payment factors have been incorporated. And we'll talk a little bit more about those on the next slide. Each year that Medicare updates its rates, what it does, and there's a listing in the final rule in the Federal Register that outlines this, they go back and they take out the prior year's update factors, reset, and then they go ahead and apply the current year's factors so that they are truly updating each year based on the new scenario. So as you can see here, this is a slide that I've referred to over the years as the Medicare giveth and the Medicare taketh away. This is truly where we see the incorporation of the market basket update that CMS implements each year. And as we have shared with our audiences, this truly is information that is cost report related. Folks see the Medicare cost report as an annual compliance filing. They're focused on bad debt. They're focused on medical education. They're looking at disproportionate share in UC. But the information contained in your cost report is absolutely vital to anything that CMS is doing. It is their window into what happened at your hospital during the year. The types of patients you saw, the cost of care, the distribution of services, new service lines that you have implemented, your charging practices, cost containment, all of that story goes to CMS through your cost report. It ends up affecting so many various areas of rate setting that we couldn't cover them today, but I just want to make that point because as we see these rules come out each year, it really is remarkable what type of information CMS uses. And in a lot of cases, they're using information that can be 2 and 3 years old. So we always have to remain diligent when we're filing those cost reports. So each year consistent, or at least this year consistent with prior years, we have several common factors. We have recalibrations for budget neutrality. We have reclassifications. We have our operating outlier factor where Medicare is removing, as you can see here, 5.1% consistent with prior years for outliers, anticipating that about 5.1% of overall DRG payments that go back out to facilities will be related to those high-cost cases. We also have adjustments for MACRA this year, and so from our previous base rate to the current year, you can see that we have about 4.7% that's being taken away for other areas that Medicare is either paying for or adjusting for. To get to our market basket adjustment right now, CMS is looking at their standard market basket rate of increase, which comes from cost report information. CMS uses what's known as a Laspers type market basket, which measures a basket of goods, the same goods and services over a period of time, similar to a consumer price index. And so what they're doing is they're taking that market basket rate of increase, but they're also adjusting it for those folks who are utilizing their EHR systems to report quality data and meaningful use of that EHR system. And then they're also incorporating several other factors related to productivity adjustments and other reductions through the Affordable Care Act to arrive at what the base market basket factor will be for the current year. So we can see if you're doing what the government wants you to, and you are submitting quality data and using your EHR system in a meaningful way, you're going to get the full market basket update of 1.35. If you are doing neither, they're going to penalize you, but you can see it's a 2.7% swing from the high to the low. So most facilities that I have encountered are going through that process and doing what they're supposed to, so we don't have a tremendous concern there. But if you are not, you can see the type of impact that it would have on your base DRG rate. This is a slide that our team really likes to see each year from the advisory board. For those folks who utilize the advisory board, when the final rule and proposed rules come out, they have a lot of really good infographics to kind of help you visualize where all of the various adjustments are coming from. So you can see here that even right about 3/4 of the way down, you can see our net market basket update in this bolded column of 1.35, but you can see that we actually have even further adjustments out from that. And this slide also helps folks visualize those adjustments where CMS applies them over multiple years to recoup certain adjustment factors like the documentation and coding adjustment or the reduction for the 2 midnight rule, those types of things. This is another great slide from the advisory board that kind of shows on a service line basis where the various payments up and payments down are going to be happening this coming year. And what's really interesting is the fact that this slide also includes what was in the proposed rule versus the final. And so you can see in some areas it's a little bit up, it's a little bit down, but it's interesting to see the distribution of services across some of these more kind of high acuity areas of patient care. So each year, CMS recalibrates the DRG and APC weights using both cost report information as well as MedPAR claims data. As I mentioned before, this is one of those areas that is so important in terms of making sure that the base data in your cost report truly reflects the patient care that you are delivering in your hospital. So what happens each year is this information goes into an algorithm to determine what the new distribution of resource consumption is at hospitals. And so there are some years where maybe sepsis through cost report and claims data looks like it's consuming more resources. Some years it could be orthopedic or cardiovascular services. So each year, if you were to take the DRG tables by the DRG codes and actually compare the weightings, you'll notice they're fluid. Some are going up, some are going down, but generally across all of them, if you sum up the total value of the DRGs, the total value remains relatively unchanged. They just fluctuate year to year based on where care is provided in the hospitals across the country. Now, it is interesting to know that in order to get to the information that they want to use for these calculations, they do strip out a fair amount of information. Hospitals that are not paid on the IPPS methodology, claims that relate to Part C as opposed to Part A. So there's a lot of modifications that CMS makes to their baseline data that's important to know, because as we make this transition in the new world order from Part A to Part C, it's interesting in parts of the country, especially, say, Oregon and other West Coast states, Medicare Part C enrollment is outpacing Part A 3-to-1 in some markets. So if you look at that trend and we look at how the payment rates are set, we have payment rates being set on a population of Medicare beneficiaries that's shrinking even though the consumption of resources is expanding. So those are the types of things in the final rule that our team likes to keep an eye on, because we want to make sure that if we get to an equilibrium point where all of a sudden there are choices being made by CMS on a disparate data set, we want to be able to comment on that and say, hey, you need to look at a bigger portion of the pie to truly understand how these patients are using services. So as part of that annual calibration, CMS takes into account the 19 cost to charge ratios across various service lines and cost centers on the cost report. This is one of the first years, and you can see between the two columns, where we have not much difference between the 2 years in cost report cost to charge ratios. So I won't spend a lot of time on this slide because I want to make sure we spend some more time with Glenn on the DISH and uncompensated care. But it is interesting to note that we may be reaching a point where charging practices are slowing down in relation to cost growth. So just something to be aware of. So for those high-cost cases we mentioned before, the final outlier threshold for this coming year will be $26,601 compared to $23,573 from last year's rule. So for those cases where you have conditions that are beyond your control, we need to get over that $26,601 cost hurdle in order to have the outlier case triggered. Capital costs, the update factor for this final period will be 1.2%. As we saw in the original slide on payment rates, we're looking at about $453 per case for the capital costs. Capital costs, another key area of the cost report, whether it's B Part 2 or B Part 1 or A7, all of those areas of the cost report Medicare looks at to determine what is the mix of cost versus owned assets that are depreciated, leased assets, what areas of the hospital are those, is that equipment or a new building area relating to. So again, really, really important pieces of the cost report that may look banal on the surface, but go to areas of CMS that could affect payment rates for you going forward. So with that, I will pass it back to Glenn, and we'll talk about one of the more interesting developing areas around DISH and uncompensated care.
Thanks, Paul. So on your screen is a slide that was also prepared by the advisory board, and this has to do with uncompensated care payments. And as the header indicates, they are increasing by more than $1 billion from the prior year, so this is good news. The uncompensated care payment is, in terms of factor 1, is increasing by $867 million. Factor 2, which measures the change in the uninsured population, has utilized a new data source that reduced the reduction percentage within the formula. So that yields more DISH dollars in the pool than in the past. And then factor 3 involves the distribution of the DISH uncompensated care pool dollars developed in factors 1 and 2 to eligible hospitals. In terms of the DISH and DISH uncompensated care payments, for background, hospitals that have a combined SSI ratio and Medicaid patient days ratio equal to or above 15% are eligible to receive a DISH payment and are eligible to receive a distribution from the DISH uncompensated care payment pool. However, hospitals in Maryland, hospitals participating in the Rural Community Hospital Demonstration Program, and sole community hospitals that are paid under their hospital-specific rate are ineligible to receive DISH. Overall, in federal fiscal year 18, the gross DISH payments are increasing from $14.397 billion in 2017 to $15.664 billion in 2018. 25% of the gross payment will be based upon the hospital's data. 75% of the gross payment will become the DISH uncompensated care payment pool. As previously mentioned, the Factor 1 DISH pool is increasing $867 million, so it's going up from $10.79 billion in 2017 to $11.664 billion in 2018. This slide that we have here pertains primarily to the calculation of Factor 2. There's a lot of calculation here, and while we don't have time to get into the minutia of the calculations, it is important to note that the uninsured population continues to decline since the implementation of the Affordable Care Act. After the Factor 2 calculation is applied, Factor 1 uncompensated care pool shrinks from $11.664 billion to $6.77 billion. So quite a haircut that happens in Factor 2. The Factor 3, which is the distribution, again, of the uncompensated care payment pool, is a hospital-specific value that in the past was developed from Medicaid and SSI ratio day information. CMS is now transitioning Factor 3 from the use of days information to charity care and bad debt information reported on worksheet S10. CMS feels S10 is more stable today than in the past, and they now feel it is reliable. In the past, they did not have, they didn't feel it was reliable, so that's why they went the direction of days. There's some big concerns out there about using worksheet S10 data for the Factor 3. One of the concerns, and probably the major concern, is of hospitals in states that expanded insurance coverage under ACA, and that's transitioning to CMS's use of worksheet S10 data. For these states, their worksheet S10 data will naturally have less uninsured, less charity care, and bad debt amounts than states that chose not to expand. States that never expanded insurance coverage under ACA will receive a greater percentage of the Factor 3 DISH payment pool as worksheet S10 data is transitioned into the allocation. So in short, if you're a hospital that expanded insurance coverage under ACA, CMS's decision to use worksheet S10 data is generally not in your favor. Nevertheless, federal fiscal year 2018's Factor 3 will be based upon the use of an averaging of Medicaid days from 2012 and 2013, SSI ratio days from 2014 and 15, and worksheet S10 data from 2014. Hospitals should expect to see worksheet S10 fully transitioned by federal fiscal year 2020. And that gets us to our third polling question.
All right. Third question is, what year will worksheet S10 data be fully transitioned into Factor 3 of the DSH uncompensated care payment pool? And your options are federal fiscal year 2019, 2020, 2021, or I don't know. And for those of you that would like a copy of today's slide deck, you can download this now from the folder that says Slide Deck and Handouts to the right of your slide view. We'll also be sending a copy of the slides via email after the webcast. I'll give everyone a few more seconds to make a selection here. And let's see what everyone thinks. Glenn, back to you.
Well, that's what I would expect everybody to pick is 2020, because we just had that on the last slide. So it looks like everybody's paying attention, and good job. With the movement by CMS to move towards worksheet S10 data, we want to make note, and this is important from a timing perspective because hospitals really have just a couple weeks left here, but hospitals have until September 30th of this month to submit corrections to their worksheet S10 data in order to get such corrections included into next year's federal fiscal year 19 uncompensated care Factor 3 calculation. We also want to make note that it's important that all revisions are received by September 30th and not postmarked. Actually, September 30th, I believe, is on the weekend, so you might want to take note that you want to get them there by the close of business on the 29th. This table, again, is from our friends at the advisory board, and it provides a great visual of the worksheet S10 transition timeline. The table also provides a good historical description of how Factor 3 has evolved over time. So please note going forward, CMS defines Factor 3 as the cost of charity care and the cost of non-Medicare bad debt. And what we found missing from this equation is uncompensated care related to the difference between Medicaid cost and Medicaid payment. Sometimes people refer to that as under reimbursements. Also missing is other state and local government programs, SCHIP, and other forms of uncompensated care. But for uniformity purposes, CMS has specifically chosen to utilize only uncompensated care associated with charity care and non-Medicare bad debt in its Factor 3 formula. So that's the reason why. It's due to uniformity in terms of why they've only selected certain components of Worksheet S10. So to recap, this table is a visual representation of the data elements used in the development of the federal fiscal year 18 DSH uncompensated care payment pool. So this begins on October 1st. We wanted to take a minute here to analyze what all this means on a state-by-state basis. So this table is intended to highlight some of the largest changes by state in terms of the amount of DSH uncompensated care payment that is forthcoming in 2018 as compared to the prior year, 2017. So as you can see in the table, hospitals in California, which is an ACA expansion state, are projected to lose more than $43 million in DSH uncompensated care payment funding in 2018. Another notable ACA expansion state losing funding is New York at more than $30 million. Now on the flip side, you have Texas, a non-ACA expansion state, and they are projected to see an increase of $219 million in DSH payment funding in 2018. So if we dive into Texas and take a look at their numbers, you'll see the top 14 hospitals in Texas are reporting huge uncompensated care costs on their cost reports. And of course, this translates into huge DSH uncompensated care payments, again, starting October 1st of next month. We wanted to also remind everybody, and we kind of do this annually about DSH SSI ratio realignments and requests. There is a provision out there in the regulation that allows a hospital to request to have their SSI ratio recomputed based upon your cost reporting year end. As background, SSI ratios are developed on a September 30th year end, but realignment allows hospitals to develop that SSI ratio based upon their cost reporting year, and this could be financially advantageous to hospitals. Just within the last year, CMS and the MACs have been implementing SSI ratio realignments. They had been on hold for a long time, so now that's back in play. We also wanted to leave you with a schedule here or a listing showing the website location for the CMS fiscal year 2018 inpatient tables and the data elements that are discussed in today's presentation. So if you, after the webinar, when you get your slide deck, you can click on that link, or you can copy and paste it into your web browser, and that'll direct you right to these tables. The next section is, the next topic is section 603, off-campus provider-based update, and I will turn it back over to Paul.
Thanks, Glenn. So section 603, along with a lot of the other provider-based related updates and commentary that's been unfolding over the last year, we just wanted to give folks kind of a gentle reminder regarding this new off-campus environment for provider-based. It really has been amazing. I would say in the last 6 months, I have received more questions around provider-based than I have in probably the previous 6 years. A lot of questions regarding, is it worth it? How does 340B play into all of this? How do you make sure that you get the right modifiers on the claims? So just as a reminder regarding off-campus, we're talking about those departments not located on the hospital campus or within a certain distance. And we're talking in terms of distance within 250 yards on a straight line of the main building and other areas as determined by CMS regional offices and on an individual case-by-case basis. The other piece of this, too, for hospitals wishing to add off-campus provider-based departments, we have some detail here regarding the enrollment forms and some of those other requirements that hospitals need to go through. But when we're talking about off-campus, one thing we did want to point out is this very important place of service, site of service that needs to be added onto the claim. So when we're talking about place of service 19, we're talking about outpatient hospital off-campus services. And then we have place of service 22, which has been renamed outpatient hospital on-campus services. Now, even prior to the implementation of Section 603, we were seeing in the rulemaking that CMS was asking for modification on claims to really see where these services were happening. So it's interesting that even before rulemaking, CMS will gently start to roll out various compliance requirements that end up creating critical mass of data for them to make decisions on. The other important piece of this regarding telerad services is based on where the technical portion of the visit occurred within the hospital's service lines. One important item note here regarding dedicated emergency departments, these remain exempt from site neutrality. So hospitals may form a new dedicated emergency department and can bill those services under OPPS to get the appropriate APC payment. So regarding off-campus provider-based billing, prior to 11/2 of 2015 are not subject to Section 603. So off-campus, if it was provider-based, and certainly there's a lot of iterations with that, the attestation process and having the various checklist items in place. But if that was there prior to November 2nd, you have been grandfathered into the OPPS payments under APCs. Now, the trick is that if you relocate or expand those departments, then we run into some issues. So we've listed out some of the more stringent criteria we have here. One of the questions that's even come up around this is, what if you have a provider-based off-campus department in Suite 101 and you want to knock down a wall and move it into Suite 102? That is even creating some confusion around that type of move as well, even if the 102 suite was previously owned by the hospital as well. So just be very careful and diligent with this, just because there's a lot of moving pieces and nuances around these various circumstances. So here we go. We're talking about the calendar year 2017 OPPS rule and a few other case-by-case situations. But I want to make sure with the time left, and we'll skip over just this one last slide, because I did want to talk about some OPPS items that have come up even within the last week. But before we do that, Emily, let's proceed to our final polling question.
All right, thank you. Our last polling question, did your organization submit comments to CMS on any 2018 proposed rulemaking? And your options are yes, no, or I'm unsure. And once you have completed all CPE requirements for today, you will be able to download a PDF of your CPE certificate from the certification window to the right of the slide view. And let's see what everyone has to say. Back to you, Paul.
All right, look at that. You can't. That's the perfect accounting slide there. Well balanced, and that's interesting. It's great to see that folks are submitting commentary. For those folks who really dig into the rulemaking, it really is important. I mean, sometimes we'll joke that we're unsure whether or not CMS ever takes these into consideration other than including them in the final rule and say thank you for your insight. But it really is important because when you submit those comments, they are included, and there are times where CMS will go back to prior rulemaking and actually revisit certain comments as they make changes in policy. So it's great to see that as well. So as we transition over to OPPS, similar to the base DRGs, we have a base conversion factor for OPPS. The proposed amount for 2018 at this point is $76 and about 48 cents compared to just about $75 that's currently in effect for 2017. Now here we talk about kind of the proposed pass-through spending for drugs, biologicals, and devices. We see that it's down significantly from prior year. And one thing to keep in mind now is the calculation for pass-through drugs has changed, and CMS is starting to look more and more closely at the cost-to-charge ratio for drugs and also with the pass-through drugs as well as the pass-through devices. And so it's really important, especially on the device side, where we're seeing folks who may or may not be appropriately splitting out their implantables versus medical supplies charged to patient cost-to-charge ratios between the 71 and 72 cost centers. So it's really important now, especially on that line 72 for implantables, that when you're looking at the charge compression that's going on, the markup versus the costs that are coded from the invoices in those departments, and whether you're directly costing them or reclassifying them via A6, you really want to make sure that you have optimized that implantable cost center because it's now impacting OPPS payments on that side of the house as well. So just an anecdote there regarding another area where cost report information is coming into play. Consistent with IPPS, and I know we're just coming to the end here, we have an outlier threshold on the OPPS side. Currently, we're looking at $3,825. For next year, starting January 1, we're looking at an outlier threshold of $4,325, and typically between the proposed and final rulemaking, we'll see a change in that amount as well. So as we wind down today's presentation, we appreciate all of you sticking in there with us. One thing we wanted to highlight is our upcoming healthcare conference. Moss Adams has been putting on this conference for more than, I'd say, 15 years at this point. We have some exciting content coming up. We have Dr. Sanjay Gupta, who will be giving a keynote address. We'll also have our annual political point-counterpoint discussion with Dr. Tom Coburn, who's a former senator from Oklahoma, and former state senator Wendy Davis from Texas. And then for those folks who have not seen Lowell Catlett in the past, he's a futurist and probably one of the more entertaining speakers I have seen, really kind of looking into what's ahead in the industry. So if you're able to, we'd love to see you there. And if you're already registered, thank you so much. It's going to be a great event. And in the slide deck that you'll receive, we have some conference feedback from folks who have attended in the past, including Senator Tom Daschle, who was one of our point-counterpoint speakers a few years ago. And so with that, Emily, I think we just have a few minutes here if there's time for a question.
All right, we could probably squeeze in one question here. Let's go with skilled nursing facility completes their own WSS3 Parts 2 and Part 3 for wage index data. Why would CMS use the hospital's wage data to SNF?
Yeah, I can answer that question, and it's a great question. Skilled nursing facilities do report their own wage index data, but I think really it comes down to consistency from CMS's viewpoint. I just from my own experience, I do see a lot of variety and a lot of variance really in skilled nursing wage index data. So probably for the same reason that they did not implement Worksheet S10 for a while, even though that had been completed by hospitals. I think it just really gets down to consistency from CMS's viewpoint, if I had to make a guess on that.
Great. Thank you, Glenn. And that looks about, we are right at the top of the hour here. If you have any questions for Glenn or Paul, you can reach out to them directly, or you can enter your question into the Q&A window and hit submit. Thank you, Paul and Glenn, for a great presentation today. And as a reminder, if you attended today's presentation in a group and would like to receive CPE credit, you must complete the group attendance sheet found in the slide deck and handouts window to the right of the slide view. If you participated as an individual and met all certification requirements, your certificate is available to download now in the CPE progress window to the right of the slide view. And I'll keep the webcast console open for a few minutes to give you time to download your CPE certificate, and a copy will be emailed within 2 weeks should you have any difficulty downloading it now. Here is a link to an online survey where you can provide feedback for today's presentation. Please take a moment to complete this survey, as your feedback is very important to us. Thank you for joining us today, and we hope you'll join us again next time.